So, hello again, good afternoon, good evening. Welcome to another broadcast from Innovation in Tel Aviv, Israel. With us today is Professor Avi Khafif from A.R.ם, the Center of Otolaryngology in Tel Aviv, in Asuta. And welcome, Professor Khafif. It's great to have you with us today. You have a presentation for us, and because of the live broadcast, I will try to stay out of the way and let you do the presentation. Afterwards, if we have any question from our audience in China or else in the world, we'd be happy to present the question. So please start, and thank you again for coming today.
Okay, so just hello, and the minute I turn on my presentation, you won't be able to see me.
That's right.
So that's terrible, but nothing I can do about it.
Yeah.
So I'm going to say hello again, and I'll meet you again at the end of the presentation for questions.
Okay.
Let me share the screen and put on my presentation. There you go.
Yes.
So I hope everybody sees the presentation okay.
Yes, we can see it.
You can see it, okay. So just for the beginning, A.R.م is actually a vision. It's a vision that we had 10 years ago when we opened our center, which aimed to show a comprehensive and professional treatment to all patients. We want to be one of the top specialists leading in the country, and we want to be updated via peer learning conferences all over the world, and we are involved in conferences all over the world, including a very big one in China, which we'll talk about in a second. We are integrating medical and social aspects of our patients in full synergy so as to provide the best clinical care for our patients. And we do lead an international collaboration worldwide, including some medical devices that we own. So 1 year ago, almost 1 year ago, we spent 2 weeks in China. We actually sent a delegation of over 30 surgeons and medical staff to 2 provinces in China, in Shandong and in Fujian province, where we actually spent 10 days, almost 2 weeks, operating, giving lectures, sharing clinical practice. We had several medical conferences attended by hundreds of Chinese doctors. We helped them in the operating room, and then we went out and drank a lot of vodka or whatever you call it there in the evening. So it was really an amazing period. We loved it. We think it was fruitful both for us and for the Chinese doctors. And it'll probably happen again sometime in the future, I hope. So here you see some pictures from China. You see the delegation, and then this is an operation, a neck dissection actually, performed in Fujian by myself and my staff, and these are other pictures. So with that, I want to proceed to the topic of my talk, which is endoscopic resection of thyroid and parathyroid tumors without a scar in the neck. So it's scarless thyroidectomy and parathyroidectomy. And we all know that thyroid surgery usually results in a scar like that, looking quite nice. This is a very good friend of mine. It's his wife. We're still friends. This is another friend of mine, and it's his wife, and they don't talk to me. And you know, the suture is exactly the same. I'm kidding, but still, you never know when to expect a hypertrophic scar. And this happens in a few percentage of the patients, not a lot, but enough to cause a significant decrease in quality of life. But even if the scar looks good, any scar in the neck was shown to decrease quality of life in about 10 to 15% of our patients. So we do want to put an end to this decrease in quality of life. We have performed a study with Johns Hopkins University in the United States where we asked normal citizens what's their attitude towards a scar in the neck. So we looked at over 1,300 patients. You see 350 from Israel and 930 from the United States, from Baltimore. And what we saw was interesting. Among the Americans, about 60% prefer a scarless thyroidectomy, which is obvious. Usually the old people did not care about scar in the neck. What's interesting is that 10% would prefer a scarless thyroidectomy even if the morbidity, the complication rate is higher, and 30% would not mind paying more for a scarless thyroidectomy. And as I said, as you get older, it matters less and less. So to me, it matters a lot. I'm very young. You don't see me smiling, but I'm smiling. Among the Israelis, 76% prefer scarless thyroidectomy, and 30% prefer scarless even though the morbidity is higher, which is amazing. You would rather be hoarse because of thyroid surgery, but not have a scar in the neck. 72% of the patients accept to pay more for a scarless approach. And we know that in the Far East, China, and other places in the Far East, a scar in the neck is really something that many women would like to not have. So it's probably important, at least as it is in Israel. And this is less important. So what I'm going to show today is a scarless approach from a natural orifice from the mouth, where we go in with endoscopic equipment, and all of you have this equipment in your hospitals back home. So it's a typical endoscopic equipment, like they do with gallbladder surgery today. They use the same endoscope. So we're not buying anything new. It's cheap. It's convenient. Every hospital has it. And with that camera, which gets underneath your lip, so it's from the inside of your mouth, you look 30 degrees angle directly to the thyroid, and then with side ports, you can take it out. These are the incision that we put in the mouth. This is the main incision, and these two cuts, which as you'll see are non-significant, even one day after. From there, we put in our trocars, and then we operate. Okay, so this is surgery as you see from the main port, and these tools come in from the sides. So here we are inside the neck, and I'll move a little bit here, and we are actually spreading the muscles of the neck right here. The skin is above, and the thyroid would be deep here. The throat is going to be somewhere here, okay? We're splitting the midline of the neck. This is the muscle on the left side. This is on the right side. And we really see everything very clearly. And not even one drop of blood during surgery, usually. Here we separate the thyroid, which we'll see in a minute, from the muscles. So it's very elegant. You can see everything. This is the thyroid already. You can see it. All of that is thyroid, actually. So then we here, let me advance. And then we go on. This is the trachea or the pipeline where you breathe from. So you can see the white thing here is the trachea. And then we cut the thyroid right above it so that we have a reference to the midline of the neck, as you'll see in a second. So now you see the entire trachea fully exposed. Very simple when you know what you're doing. In any surgery, you gotta know what you're doing, I hope. And then we keep freeing, let me proceed, keep freeing the lobe. This is the lobe of the thyroid, which is very enlarged, very pathologic. We want to remove it. This is the main artery of the neck, the parotid artery. And then we take out the upper part of the thyroid. Here we're cutting the blood vessels to the upper pole. We're using this special instrument to cut them and ligate the vessel. Here we take another, you can see here a little vessel coming down and we just burn it and cut it. This is, you need this instrument to make, to proceed with the surgery. And the most important thing is thyroid surgery is to preserve the parathyroid gland and the nerve to the vocal cords, and you're going to see it in a second. So here you see the parathyroid gland, which is, and this is the nerve to the vocal cord right there. You can clearly see it beautifully here. And then we take this little blood vessel. Here I touch with the nerve monitor the nerve, and I know for 100% that it is the nerve. Then I take this blood vessel. Once I take it, the nerve falls down, and we can easily remove the parathyroid, the thyroid gland outside, preserving the parathyroid, the upper one. This is the lower one, and the nerve is right now is under us. Where is it? Right there, right here. So we're moving here, taking out the lobe, and we're almost done. So it's very, again, this is the nerve here, parathyroid, and the lower part. So we've done it without any injury to the patient. This is the trachea again, and we separate the rest of the thyroid from the trachea right there. There it is. We put it in kind of an endobag, exactly like, again, they do to gallbladders, and remove it outside. This is the area right after we remove the thyroid lobe. Looks clean. No drains, no sutures, only sutures, resolvable sutures in the mouth, as you'll see in a second, and the surgery is done. Very simple, isn't it?
Looks amazing. It looks amazing.
Yeah. This is a little bit different. You're going to see a parathyroidectomy. So in the previous patient, the thyroid here was the one with the disease. Here we see below the thyroid is this little thing here, which is not so little as you see here. This is a parathyroid tumor. So we're leaving the thyroid and we're taking the parathyroid. It's a different operation, but the same technique. You can clearly see the blood vessels. We're ligating them. No blood during surgery. This is just connective tissue which is separated. The field is very clean. The operation is very, very elegant. And then we take it out, burn the blood vessels, and again, put it in an endobag and remove it. This location is probably the easiest for parathyroid adenoma. Sometimes it's more difficult. So here we take it out. In this case, I'm just showing the location of the parathyroid. As you see, this is the nerve, and the parathyroid is being delivered underneath the nerve, which is very dangerous in open or endoscopic surgery. So it's possible to do any of these surgeries endoscopically. So this is the operations. This is a medical student 1 week after surgery. You cannot tell she had any type of surgery to her neck. She's graduating next year, and she wants to come and work with us at least for a while. And this is the absorbable sutures in the mouth. She and every other patient eats normally 1 day after surgery. And as you can see, you cannot tell she had surgery. There's another patient, she's 16 years old. And another one, 3 weeks after surgery, no indication she had any type of surgery. This is the youngest boy operated in the world during via this approach. He was 10 years old. He had a malignant thyroid tumor, which was removed. And this is 3 days after surgery. Again, you cannot tell he had any type of surgery. So altogether, we did, in this report, we are reporting 91 patients. We already got to 100 patients using this procedure. And most or half of the thyroidectomies were for malignant process. The parathyroids are always benign, almost always benign. And the operation was successful in all of them except one patient where we had to open the neck. And this patient was told in advance that most chances we're not going to be able to do it endoscopically. So we really finished the procedure in every patient we planned. The mean time was the average time was 2.5 hours, but as you'll see in a minute, we're getting better and better with the time-wise. All patients were discharged on operative day 1 except 3, and no permanent complications occurred, and this is probably the main sentence you're going to hear today. This surgery is exactly the same in terms of mobility as open surgery. So there is actually no reason to operate, especially young women with a scar in the neck, when you can do it scarlet. Oops. This is our learning curve. So this is the first 20 patients, the following 20 patients, and then the last 10 patients. You can see a significant drop in time. Here we're averaging about 2 hours. I think today we're more towards 1.5, 140 minutes, and I'm hoping to get to about 1 hour, 1.5 hours at max. So it's a very nice learning curve which we're having. And the results are excellent. I'm not going to go into details, but all the tumors were removed with negative margins, which means we removed the tumor entirely. And in the parathyroid glands, all the calcium level normalized after surgery. 6 patients had transient vocal cord paralysis, which is in agreement with the literature. In the last 40 cases, we dropped down to about 3%. And the rest of the mobility, the complications were non-significant. So we conclude that transoral thyroidectomy is suitable for selected patients. I did not talk about it, but not every patient can have an endoscopic thyroidectomy. I just saw a patient 10 minutes ago with a 10-centimeter metastasis from a thyroid cancer. Obviously, he needs a large surgery in his neck. But for tumors up to 4 centimeters, or for malignant tumors up to 2.5 centimeters, we can do it endoscopically very easy. And the results are comparable to the open approach. Again, you must choose your patients. Not everybody can do it. So with that, I want to move on to a little different topic. We have some time, right?
Yes, yes.
Okay, so I'm sure all of you visited the gay parade in Tel Aviv.
Of course.
It's not a mistake, but actually we've thought about it, and we said, if we're doing an endoscopic surgery to the neck, why not use it to shave the thyroid cartilage or Adam's apple in men or transgender women? And we've actually started dreaming about it about 1.5 years ago. And we've actually manufactured a specific shave for this procedure. Then we tried it on cadavers, and then we got our Ministry of Health approval, and we operated already on several patients. And this is what we do. We start exactly like the thyroid. We actually divide the muscles of the neck. And here you can see Adam's apple, very bulgy, okay? This is a transgender woman. This is part of her gender identity change. And what we do is actually separate the inner and the outer covering of the cartilage. The vocal cords are going to be somewhere here, okay? And then we cut the cartilage. We flatten it completely. Little blood so that you know that I'm a surgeon and not a pharmacist. Today we use this electronically so it doesn't bleed at all. This is the shaver. So we're using it until it's completely flat. As you can see here, no bulge at all. You'll see it in a second post-operatively. So this is again a special shave, a different one. And then we suture the muscles again, just like we do in thyroid surgery. And this is the end of the procedure. This is our first patient before surgery and after surgery. This is our second patient. So we operated on 7 or 8 patients already. All of them were successful. All of them were very happy, and they filled out the quality of life questionnaire specifically for that, and they scored about 95% satisfaction. And so we've actually described, and it's already in the literature, we published our first 4 cases in the English literature. This is a novel approach. Nobody ever used it for that procedure. And we're very proud to be the first one to describe it. And so far, it seems feasible, safe, and with excellent results. So I want to thank you for your attention. I hope you understood all of what I'm saying. But if you have any questions, I'll be happy to take them right now.
Okay. First of all, thank you, Professor Khafif, for the amazing presentation. This is a great technology, and for me it was fascinating to watch the videos. I know that not a lot of doctors around the world are familiar with this kind of technology. And my question, I have a question before we see if the audience have a question. What is the learning curve? How much time does it take for a competent surgeon to learn how to use this new technology?
So we have just sent a paper out for publication with our first 70 patients.
Mm-hmm.
And what we're talking about is for a person like me who is not a general surgeon. I'm an otolaryngologist.
Yeah.
I've never used endoscopic or laparoscopic technique.
Mm-hmm.
And the learning curve is probably a little bit slower than the general surgeon. However, my practice in thyroid is about 4,000 to 5,000 patients.
Yeah.
So it helps a lot in moving on to endoscopic procedures. So after 30 cases, I think we're dropping down significantly in time. After 50 cases, we are almost the same as open.
And do you feel that there is an advantage in using endoscopic technique for this kind of surgery because of all the very complex anatomical barriers that you have in the area and all the blood vessels and the nerves? Does it gives you any advantage to use this technique?
In a way, it does, because instead of looking, and I'm doing very small incisions for thyroid surgery when I do an open surgery,
mm-hmm.
but instead of using a very small incision,
mm-hmm.
you can see on a huge TV,
yeah.
and the nerve look like that,
mm-hmm.
and not like a little spring. And it's very easy to identify it. And we use a nerve monitor, which, as you saw, you can touch the nerve and it beeps.
Yeah.
So that it seems safe. The direction of surgery, as I use it openly, is also from above downwards. So it's exactly the same way. So it seems like a natural thing to do. Again, it's not for every patient. I wouldn't do it for an 80-year-old gentleman because I want to get out from operating room as soon as I can.
Mm-hmm.
But for young people, I mean younger than myself, obviously,
mm-hmm.
and I would use it, yes.
Yeah. Okay. Can you say a few words about the thyroid and the parathyroid glands, because we mentioned them in the presentation, but not all of the audience are familiar with the function of the gland. So in just a few words, what is the purpose of the thyroid and the parathyroid?
That's simple. The thyroid is actually in charge of all the energy, sort of say, of the body.
The metabolism.
So it secretes one hormone, the thyroid hormone, which is actually responsible for your energy level.
Yeah.
And you cannot live without it.
Yeah.
If you take out the thyroid, you need to replace it.
Yeah.
The parathyroid, there are 4 small glands, as you saw, very close to the thyroid gland, and they're part of the calcium metabolism. So if we take out one gland, nothing happens. If we take out 3 glands, nothing happens. If a gland is diseased, it secretes more hormone, and the calcium level in your blood gets high, which is not good for you. Then we take it out.
Yeah, I understand. Okay. Unfortunately, the time is our time is over, so we don't have time for more questions. But I would like to thank you again for the fascinating presentation. This is the technology that we expect to see in the next years, and I hope that it would be much more prominent and you use it more often because it looks amazing. Thank you very much. Thank you for joining us.
Thank you, everybody.
And Have a good evening or good afternoon to our viewers. Thanks again.
Bye-bye.
Bye-bye.